for that introduction. I'd like to start by acknowledging the traditional custodians of the land on which we meet today, past and present, and also to acknowledge any elders that may be with us today. I'd also like to thank Luke for inviting me down here today to talk about my favourite and first love, Kirketon Road Centre and the primary healthcare model. It's also good for us Sydney-siders these days to get out and about and see a bit of sun. Be surprised to know that we're now coming to Melbourne for the weather. Sorry, it's attached. Okay. So as I say, Kirketon Road Centre's primary healthcare model has been my sort of life's work in many ways. It's the first sort of proper job I got as a doctor, having graduated from 1987 when it was first established. So I was there from day one and became its director in 1989. Kirketon Road Centre was established in response to a recommendation of the New South Wales Select Committee on Prostitution, recommending that New South Wales Government fund a multi-purpose healthcare centre in the King's Cross area. So originally very much focused on health needs of sex workers, which at that stage were not met by services in King's Cross, which of course, as you'd probably appreciate, is the epicentre of the sex industry in Sydney. The committee recognised that existing clinics at that time and health services were not generally well adapted to the needs of sex workers and may in fact be avoided, suggesting that that could be overcome by establishing a centre with a more flexible outreach and drop-in services, and that it should be fully accessible and acceptable to sex workers. The centre would not be solely identified with an STD clinic. It would instead also offer general health care, counselling and a range of other relevant services, and that recommendation's tabled in the Rogan report of the Parliament of New South Wales at that time. Probably especially to people in Victoria, because although this model was first established in King's Cross, it's probably been replicated, or the primary healthcare model has been replicated here in Melbourne more so than in any other jurisdiction in the country, with at least 5 primary healthcare centres here targeted towards the needs of people who inject drugs and other marginalised populations. So probably particularly here, you know, it would strike you that it'd be odd that, you know, a primary healthcare service integrated with a wide range of services would be considered a kind of a radical thing. It always sort of seems pretty obvious to me. The fact that I'm still getting around the country talking about it, though, suggests that despite the fact that it seems a fairly logical way to go, it hasn't been replicated to any great extent, and I'm not quite sure what the range of reasons for that are, but it was certainly considered a radical idea at the time and still remains quite rare, particularly in the Sydney context. We used to actually be on Kirketon Road, hence the name, the Kirketon Road Centre, but we moved in 1992 up to space above the Darlinghurst Fire Station, the building there in the photograph, diagonally opposite the Coca-Cola sign on the King's Cross overpass. So we still share the building with the fire brigade. They're on the ground floor and we're on the first, second and third floors. It's an interesting marriage. But it's a very central location right there in the middle of, well, actually at the location of King's Cross, which is the crossroads of Darlinghurst Road and Victoria's Road in Darlinghurst King's Cross. So the service aim is to prevent, treat and care for HIV, AIDS and other transmissible infections in at-risk young people, sex workers and people who inject drugs. So before too long, and in fact before opening the service, it was appreciated the crossover between these populations, and it was just at the time where there was an increasing recognition of the risk of HIV, and it was, so in fact it was HIV monies that were identified to fund this facility in the first instance, and our target populations were expanded to include the 3 target populations, although appreciating the overlap between the 3. And our catchment's the northern sector of South East Sydney Local Health District. We've gone through networks, districts, areas, and we're back to districts now. And that district, at this point in time anyway, goes down to the Sydney Airport. So we take in the area sort of across from the coast to the airport and up to the central business district of Sydney. 95% AIDS program funded at this stage, and 5% drug program funded for our methadone program, which I'll talk a bit about in a moment. We started with 7 full-time equivalent staff. As I mentioned, I was there at the beginning. I was a part-time doctor on the Wednesdays. And now we have about 40 full-time equivalent staff working from a couple of locations. We work under the banner of Health for All, and this is going up the stairs as you'll see a mural in our stairwell. And we work under the primary healthcare. So not only are we a primary healthcare service in the sense that we're the first point of contact with the healthcare system for many people, we also embrace the primary healthcare philosophy as articulated by the World Health Organization at its conference at Alma-Ata in Kazakhstan in 1978, embracing the concepts of acceptability, accessibility, affordability and equity. Again, these don't seem like sort of groundbreaking things. It would seem obvious that services should be acceptable and accessible and affordable and equitable, and yet particularly those of you who have worked in the hospital system might appreciate, you could be forgiven for thinking that most of the larger hospital-based system is in fact custom-made to make access quite difficult. And so in this sense, I still think it's sort of a rarity and sad that it is still the case, rare for services to actually spend a lot of time thinking about how they can be more accessible, particularly to these populations. Again, I worked down the road as a medical student and as a junior doctor at St Vincent's Hospital at Darlinghurst. That was my where I did all of my training. And I certainly didn't see the doors wide open for people in these populations. In fact, usually as soon as people woke up from their overdose back then in the 70s and asked to leave, they were very rapidly presented with a sign out against clinical advice form. I rarely saw anybody actually advising anybody to stay. So moving further up the stairs to the clinic reception, needle syringe exchange, showing our age, we're still using that terminology, exchange. We very much work within the harm reduction approach. We operate along a continuum from harm reduction through to abstinence, depending on where the client's at that particular time. We have an eclectic and a flexible approach insofar as we don't believe that there's any one particular type of treatment that is appropriate for all dependency. It's a case of horses for courses, and also at an individual level, what might be appropriate today might not be appropriate in 4 weeks' time or in a year's time. So again, we try to tailor our advice to the needs of the client, and of course also in line with the evidence. We are non-judgmental and respectful of people's chosen lifestyles, but there's a strong emphasis on ensuring that people's choices are informed. Again, non-judgmental. I've yet to meet someone who describes themselves as judgmental. But again, if you look at the surveys that we undertake on a regular basis in relation to the satisfaction with the service, overwhelmingly that's the comment that we get. People note over and over that staff are non-judgmental and respectful and how much that's appreciated. Whilst that's nice, gratifying for us, I suppose what it sends home to me, though, is that clearly that is an unusual experience still in this day and age. I'm pretty sure if a local GP ran a survey amongst their patients, there wouldn't be too many that noted that the GP was non-judgmental. I would imagine that most patients in a general practice would expect that and would only note it if that wasn't the case. So I think it's kind of poignant that clearly the experience of the people we see, it's a rare and certainly exceptional, clearly, that they are treated in a respectful and non-judgmental way. We are client-focused as opposed to being staff-focused. Again, Most health services will claim this, but again, it's been my experience, particularly in the bigger institutions and the bigger the hospital becomes, the more the policies are directed towards staff needs and not necessarily towards patient or client needs. If you're wondering why you get woken up in a hospital at an ungodly hour to get washed and for the room to be all sort of tarted up and so on, that's mostly to do with the nursing shift finishing at 7 and not really to do with the fact that you would have rather slept in to get a bit of good sleep. We're committed to the principles of health promotion and community development in accordance with the Ottawa Charter, which I won't go into detail about. I hope some of you are aware of the Ottawa Charter. It's a very inspirational document, even though now it's some years down the track since it was drawn up. As you can see in our waiting room, we have colourful posters and try to make the atmosphere a less clinical one, not too sterile, but at the same time we are in accordance with all of the requirements. We are part of Sydney Hospital, Sydney Eye Hospital, part of the government health hospital-based system, and we do meet ACHS accreditation standards on a regular basis. We're also population focused as opposed to disease focused. As I mentioned before, we target 3 populations and we seek to provide for all of the health and psychosocial needs that those populations may have, even though our primary aim is focused at prevention, treatment and care of transmissible infections, including HIV/AIDS and sexually transmissible infections and the hepatitises. We are predominantly population focused. And again, that's quite rare in the health system, which tends to be disease focused. We hear about diabetes centres or skin clinics or AIDS clinics, STD clinics. It's rare that we hear about services that actually focus on what a population needs in a holistic way. We recognise that health encompasses the physical, emotional and social well-being. We also provide services in a not only confidential way, but in an anonymous way. And there are laws requiring particularly health services within the government sector to observe confidentiality of medical information. Being able to enable anonymity is a whole other level. And we believe that that's very important, given that the people that we target almost necessarily are engaged in illicit behaviours, and particularly with many pushes towards central electronic medical record systems. And so we are holding out from those systems. Even attending the Kirketon Road Centre, as innocuous as its name might be, and you could just go there for a cough or a cold, and you don't have to be a member of a target population to get services at Kirketon Road. That in and of itself could be quite stigmatising, particularly years down the track when you may no longer be a member of those populations. So we believe that to ensure the acceptability of this service, it's very important to have an anonymous system. So we register people using first 3 letters of surname. People can call themselves Mickey Mouse, in which case they're registered as Mickey MOU. We just ask that people try to remember whatever name it is that they gave the last time, so that there is some continuity in the medical file. There is some value in that, obviously. But that's not always, that's not absolutely necessary. But we've found now, being around for 25 years next week, that our credibility on confidentiality is very high in the community, such that people do actually usually give us all of their correct details. But as I say, we are certainly not planning to join any centralised systems, even though we are part of the government health service. We don't operate under the Medicare arrangement, and that also enables us to provide this anonymous system. If we were operating under Medicare, there would be requirements to verify personal ID for people to have Medicare cards. Although everybody virtually that we see would be entitled to a Medicare card, often they don't have those Medicare cards, and as I say, we don't want to necessarily go through the steps necessary, which would involve verifying personal ID each and every time they came, potentially. It's free of charge, so no cost to consumers. We also have a pharmacy, and we dispense medications free of charge as well. This is, of course, to enhance people's adherence to whatever treatment it is that we're prescribing and dispensing. It's a drop-in service with extended hours, but there are appointments available. And we provide the service using a multidisciplinary team of nurses, doctors, counsellors, outreach workers, educators, and we encourage extension of roles, so blurring of roles, so little demarcation where possible. We minimise that again, rather than sending the patient to see, you know, this practitioner followed by that practitioner. Often, again, I think mostly meeting professional needs, not necessarily client needs. That said, there is, of course, also delineation of roles and an appreciation of the different skills and expertise that those different disciplines bring to the table, particularly with more complex cases. And we are finding over the last 10 years, particularly since the reduction in heroin supply, although there are less drug users in the area of Kings Cross, those that remain tend to have a much more complex picture, particularly with mental health in the background. A lot of the time, the heroin shortage not having made a difference, of course, to people with those sorts of risk factors. And we operate on a professional model as opposed to a peer model insofar as people are recruited on the basis of their qualifications and their work experience, not their life experience. That said, people who do have pertinent life experience are certainly not excluded, and quite a proportion of the people that work at Kirketon Road Centre have in their pasts been members of the target populations. Here's our methadone unit. There's a doctor and a nurse providing methadone across the counter there. You might also notice there the lack of barriers. When we introduced methadone to the service, we didn't want to go down the track of the other methadone clinics in New South Wales. I'm not exactly sure how they look here, but in New South Wales they're very high. Usually they're very high volume units. They're usually standalone methadone units. They often see up to 300 people a day, pushing people through very quickly, and they have very high security arrangements. They look like sort of bank teller situations with, you know, methadone sort of being passed through the barrier. We had philosophical opposition to that, having created an atmosphere that we believe was warm and friendly and welcoming in keeping with the primary healthcare service. We didn't want that to change. We did actually discover when we read the guidelines for methadone clinics, there is no reason for all of that security, even though that's been assumed by many of the methadone clinics. We do, of course, have the methadone in a safe and have an alarmed premises and so on, but that doesn't stop it from actually being delivered in this sort of a way. There's a nurse there who's, all of our nurses have had post-basic training in STD management and care, and so we do microscopy on site to be able to diagnose and treat STIs at the time when people present. That's our organisational chart, a fairly standard looking sort of chart with the sort of units in disciplines like that. As I say, about 40 full-time equivalents now work at Kirketon Road Centre, and that includes special project staff. So listing the services in 2012, I won't actually read right through them, but as you can see, we move from general medical care so people can come with a cough or a cold, but mind you, before they know it, they will be answering some personal questions about how they have sex and whether or not they inject drugs, because our overall aim is to zero in on people's personal risks. So the way that we affect our service aim is we make an assumption that people who are members of those populations that we target are potentially at risk. We try to provide a broad-based service that will be appealing to these populations, knowing also that other services are either absent or not particularly appealing to these populations. Once there, though, we do start honing in on the risk, trying to identify at that individual level what their level of risk might be in order to provide tailored advice about how to reduce their risk. So yeah, we have HIV, hepatitis services, sex worker checkups, pap smear contraception, drug and alcohol counselling assessment and referral. Moving then on to the methadone access program. This is a very low threshold program with an intensive case management approach. that has proved especially accessible to the most marginalised among the people who inject drugs. We set up this program back in 1992. At that stage, methadone programs generally were much higher threshold. We found that people who were engaged in the most risk behaviour were the least likely to be able to access methadone treatment. The evidence was already strong that methadone treatment, along with NSP, was very important as far as reducing risk behaviour. And so we decided to establish a program that was particularly accessible, where they wouldn't need to jump through the sort of hoops that were necessary at that time to get on other programs. The methadone program more generally in New South Wales and right across the country has become a lot more flexible since 1992, with the appreciation of its role potentially as a harm reduction, HIV transmissible infection prevention strategy. But even still, we find that by having extended hours and not having the same sort of ID requirements and so on for this program, and also having a smaller program rather than these large volume programs that of course have difficulty addressing the sort of more complex needs that individuals may have. So this program only doses about 60 people a day, so it can be much more focused and have a much more comprehensive case management approach. So we found that without actually having as a criteria needing to be doubly marginalised, we did particularly find that Aboriginal people who injected drugs were underrepresented on the New South Wales program, representing probably about 10 or 12% of the injecting population. Generally, they represent only about 4 or 5% of clients on our state program, whereas on our program they've been up to 33% of the program have been Aboriginal clients. So we've specifically looked at that, and what we found was that being able to form that more trusting personal relationship with clients was particularly important for that more marginalised population. Again, we didn't find any sort of substantive differences. It was more that the needs of our client base were amplified when it came to people, to Aboriginal clients who, as I say, I think, you know, we could reasonably say are additionally marginalised due to their Aboriginality. So this program has, as you saw from the photo, has been provided in a sort of more relaxed, less sort of mechanistic way, sort of more organic way maybe than some of the other programs. And but it is an access program, so the idea is that once we stabilise people, we then move them on to other programs. And we sort of aim for that to happen between about 6 and 12 months, although that will vary depending on the individual situation. We also run a lot of client support and activity groups, health promotion and community development activities are very central to what we do as well. We have a monthly calendar for our health promotional activities. So up front, we consult with clients about what the issues are. We also, of course, do a bit of an environmental scan as far as what the sort of pressing issues are for the next week. We also look at when the various awareness weeks are so that we coincide with those. And then all aspects of our service will carry health promotional messages in keeping with that particular month's focus. We also evaluate that. And we also are in partnership with a lot of other organisations in the area so that we can even extend this sort of these monthly themes across to other services in the area, really sort of being able to sort of penetrate, hopefully, those important messages. We provide housing, social security and welfare assistance, and of course a needle syringe program. You know, very crucial still today as the key way in which we prevent transmissible infections among people who inject. That includes a needle clean-up service, so that's a full-time service Monday to Friday. We have 2 primary NSP sites, and we also are responsible for 9 secondary NSP sites in that greater area down to the airport, as I mentioned. We also manage 9 different vending machines in different locations. and 3 dispensing chutes. They look like vending machines, except that they're not operated by money. They're not mechanical, or rather than electronic, they're mechanical, where you just pull one out and another one drops down. In a few locations, including a safe house, which is like a quasi-brothel where street-based sex workers work. Up the stairwell again, as you can see, we're a bit tongue-in-cheek in our humour here. I'm not quite sure if it's God passing the needle, syringe and condom to David or the other way around. We've just literally 2 weeks ago opened a new service, our second primary NSP site at 180 Victoria Street in Potts Point, moving our service previously known as K2 on the main street of King's Cross across to Victoria Street, which is 1 street back from the main drag in King's Cross. As you can see, another beautiful heritage building, 3-storey building. This has enabled us to provide a broader-based service. At the K2 site previously, we could just do over-the-counter services, which was limiting in the centre of King's Cross. Particularly at this new site, as I said, opened just 2 weeks ago. We now also, as well as NSP, we have nurse-led what we call late clinics from 1:30 until 9 p.m, Monday to Friday, where we provide the full range of primary healthcare services, but nurse-led. And this is particularly targeting sex workers in the main street of King's Cross who are club-based, who often are not out and about during the day and don't access conventional services during business hours. So this service is particularly targeting that group of people. Being off the main street is better for a sexual health service, we've found, and particularly because the operators of the strip clubs are watching where their sex workers are going. So having a service that's not a shop front, as K2 was, is also useful from that point of view. We also run an extensive outreach program with a bus, a van, people on foot, 7 nights a week. Oh, sorry, the NSP at the 180 Victoria Street is 7 nights, evenings a week. The clinical service at this stage is 5. The outreach program is in the area 7 nights a week. We do joint outreach also with New South Wales Users and AIDS Association, the Gender Centre and the Sex Worker Outreach Project. They're all consumer organisations representing the client populations that we see. We also run youth clinics at the Wayside Chapel, Oasis, the Mott Centre, East Sydney High. These are weekly clinics that we run with nurse, counsellor and outreach worker. This is part of our work, sort of upstream work. This is working with young people who haven't necessarily made the transition to injecting, and what we're trying to do there is actually to assist in preventing that transition, and if that is unsuccessful, then we have already formed a relationship with such people so that if and when they come to the King's Cross area, they have a relationship with us already and start using our service straight up. What we know from the sentinel surveillance work that we've done at Kirketon Road in relation to hepatitis C is that about 1/3 of the young people under the age of 20 have already acquired hepatitis C by the time they first visit the NSP at Kirketon Road Centre, and another 1/3 have seroconverted in the next year. So clearly our prevention programs aren't necessarily getting to people soon enough, and hence the sort of moving upstream and hoping to make contact with people and, as I say, form therapeutic relationships earlier so that we can get to people with the information and, of course, the means of prevention, i.e. needles, syringes and other injecting equipment before people have already acquired hepatitis C. So we also run special projects, including an Aboriginal project, and I'm proud to say that just last week, Brian Doyle, our Aboriginal project worker, was the proud recipient of a New South Wales Health Award, the Gail May Award, which is a very prestigious award for a person, an individual who has made a real difference at a state level in New South Wales, and that's in all of healthcare. So for us to get the Guernsey there was a very proud day, of course, for Brian himself and for the service more generally, so we're particularly proud of that project. We've been involved in Save a Mate training in partnership with the Red Cross service. This is focusing on overdose prevention training with peers and with carers and families of people who have drug users among their families. And we've also been involved in the Potty project, which has been rolled out across the state. That is a prevention of transition to injecting project, which also I think has been presented here in Victoria a couple of times, and also been replicated in Indonesia and Tajikistan and New Zealand. And we're involved very actively in healthcare worker outreach training and NSP and primary healthcare training. And finally, we are a sentinel surveillance site, both for hepatitis C monitoring. We're in a unique position insofar as being able to actually monitor incidence, not just prevalence. So this is because we're able to test people for hep C serially across time. We're able to identify incident cases, which of course tells us a lot about how effective our prevention programs are. And as I already alluded to, this has provided us with information to show that we are of limited effectiveness, at least for young people soon after injecting. And we are also part of the IDRS, illicit drug reporting system, which monitors drug trends right across the country. We have a public health research position, a full-time dedicated position that is employed through the Kirby Institute, previously the National Centre in HIV Epidemiology and Clinical Research. I can see why they went to Kirby. And that position is actually funded by us and is co-located between us and the Kirby Institute, focusing on evaluation of Kirketon Road Centre's various services. And the development of all of these services, I should add, and it's another presentation, have all been informed by evidence that has been generated at Kirketon Road Centre. Generally, we identify a need. We're then able, in a systematic way, to actually describe that need, introduce an intervention, and then evaluate it, and then, depending on the outcome, be able to make that part of our clinical practice. And so this has allowed the service to evolve over time in an evidence sort of way, and also in a timely way. If you were going to be putting in for NH and MRC grants to explore what we're seeing on the coalface, those things might long be over by the time that came through. So that enables us to have a very timely response. It also enables the public health research field to be informed more quickly and for us to disseminate findings. So it's a sort of a nice marriage too, where we inform our service with evidence and the service has an opportunity to inform the research field. There's our outreach bus that goes out every night of the week. You can see a nice big sign there, Sydney Hospital. Outreach services are still, particularly when they're parked in a suburban street, still do attract some attention. So we, as you can see, we're emblazoned as far as looking like a sort of mainstreamy sort of health service. This is our clinic van. We actually take this. This is a custom-made van that was actually, the money was raised by the Lions Club, the Sydney Lions Club. I'm pretty sure you probably have a Lions Club down here in Victoria. They're like Rotary, fairly conservative sort of constituency. Interestingly, about halfway through, they said, as long as this Kirketon Road Centre's got nothing to do with that dreadful injecting centre place. I did have to tell them that that was my other job, but I did say, no, nothing to do with that place. But I think that it was a journey for the Lions. This is the clinic van that we take to other services and run the nurse-led clinics in the youth services that tend not to have a facility to provide clinical services. That's Clover Moore, our Lord Mayor, who's probably known down this way, and that's our Chief Executive of the Sydney Local Health District. Getting that sort of executive support, I think, has been very important for a service such as this for credibility and ongoing support in tough times. Just some numbers, some daily occasions of service there. In terms of visits to K1, our main headquarters above the fire station, there are about 50 to 100 clinic visits a day. Medical nursing, counselling, you can sort of see the spread there. As I mentioned before, about 50 to 60 visits to attend the methadone program. About 50 to 80 visits to pick up needle syringes and other injecting equipment. K2 is, say, closed 2 weeks ago, but up until recently, 50 to 100 visits there a day. Outreach contacts a night, 20 to 40. Needle syringes distributed up to 1,500 a day. And in total, that all adds up to about 50,000 contacts per year. So we're having quite good penetration of this population in the area through our various arms of this service. Just looking across them, these finish in 08, but you get a bit of sense of the total number of individual clients there. About 2,000 people that we're making contact with in the course of a year. Some population estimate work that was undertaken in relation to the evaluation of the injecting centre some years ago suggested that there's a sort of resident IDU population in the area of about 1,200. So this is across a year. There's a high transience in the area. So there we see new clients. Probably about half of those 2,000 are actually new people. But whilst there's a high level of transience, what we found is that people do come back. So when we first started, we thought we'd probably just be seeing people once or twice and possibly never again. But we've actually found that over time that's not the case. There is a bit of a sort of rotation from King's Cross down to Long Bay and other correctional facilities, and then sometimes up to Byron Bay, and then back down again, depending on the weather. They'll probably start coming to Melbourne soon. But yes, people do actually come back. So there is a surprising level of continuity of care. And between the populations, you see the sort of spread there. About half identify as injectors, about a third are people who are working in the sex industry, and about a quarter people who are under the age of 25 and who are working in the sex industry and or engaged in drug use. More pictures, doctor seeing one of our staff pretending to be a client. Our wider influence, heavily published publications, including articles in peer-reviewed journals, textbook chapters, monographs, commentaries, mostly focused on harm reduction, primary healthcare model, HCV, epidemiology, prevention and treatment, opioid and psychostimulant substitution treatment. We ran several trials of dexamphetamine and more recently modafinil as substitution treatment for people with psychostimulant dependence. And also we've recently completed a trial using financial incentives to see whether that had an impact on uptake and completion of hepatitis B vaccine, soon to be published. This is using randomised controlled methodology, and we did find a difference. Unsurprising, we find that child immunisation, all the immunisation uptake and completion is better when there are incentives. Interesting, though, to see more resistance when it comes to providing those sorts of incentives to people in populations like this than it is to, you know, middle-class mothers with a child. Sorry, you're sort of probably getting a little bit of my bias coming through there. So we've also provided advice to World Health Organisation, AusAid, USAID and other international development organisations and conducted missions in Indonesia, China, the Philippines, Laos, Malaysia, Vietnam and Central Asia. We've been represented on UN reference groups, national, state, ministerial, local community committees and NGO boards and management committees. Getting to the end here, this model has proven acceptable to vulnerable populations as demonstrated by the utilisation of the service over the years. We have been able to comprehensively address complex issues with a multidisciplinary team. I believe it's a humane and compassionate approach. I think that this sort of service model is also less vulnerable to service stigmatisation than standalone methadone clinics or standalone needle syringe programs. and disease-focused clinics like STD clinics and AIDS clinics and the like. It's proven to be politically robust and versatile because we do address things comprehensively. We do address underlying issues, antecedent causes. We're working at all levels, as I say, from before people make transition to injecting right through until people are injecting in unsafe circumstances. So it's comprehensive and holistic in that way too. We found it's readily adaptable to emerging needs. We were established well before there was a test for hepatitis C and before we realised that over half of the people we were seeing were affected by hepatitis C, yet we were able to gear up very quickly and effectively to meet those challenges. It's a professionally challenging model, being able to be involved with people rather than referring people who have a family planning issue to a family planning clinic, or a drug issue to a drug treatment clinic, or an HIV clinic, whatever it is, to be actually sort of able to see people through and be involved in case management. Also, we've found translates into professional satisfaction, and that reduces turnover, which is really important also for continuity of care. These are client populations that are often not used to a lot of continuity in their life. Being able to develop a therapeutic and functional relationship with people who are committed to working with these populations, I think, is in and of itself a very important thing that we offer. And also, of course, efficient and effective to be providing things under the one roof, again, instead of sending people from pillar to post, many a time, of course, which will simply not actually result in the person actually turning up at the other end. I'd like to thank particularly the staff of the Kirketon Road Centre who do this challenging work. It's not always pretty. Also the socially marginalised clients for whom the service was established and who we serve. The executive who has supported this service through thick and thin, as I already emphasised. I think it's very important to have mainstream health executives on site and to fully understand what we do so that we're not marginalised services ourselves, which is the risk, I think, that you can also absorb the marginalisation of the client population and become disempowered yourself as a service. It's been almost 25 years, as I said. Our birthday's next week. So thank you for listening.